In our today video, we're gonna look at the different types of headache and their signs and symptoms or their presentations. Also, we're gonna look at the pathophysiology of different types of headache, and also we're gonna look at the different management of different types of headache. So, first of all, we need to know what is the definition of headache. And actually, the definition of headache means pain in the head, and we need to know what causes pain in the head. Is normally irritation or stimulation or agitation of muscles of the head, or agitation, stimulation or irritation of the dura mater, or irritation or stimulation or agitation of cranial nerve number 5, that is trigeminal nerve. So sorry, here should be number 5, trigeminal nerve. So let's proceed. So let's look at different types of different types of headache, and we have primary headache, and we're gonna look at the first one, that is migraine headache. How does migraine headache? Migraine headache does not have defined cause, but it is believed that some is caused by genetic factors. Maybe some genetic factors can cause this type of migraine headache, but we have some most common triggers that include red wine, cheese, or oral contraceptives, or stress, or chocolate product. These are all the triggers. What happens when you take these triggers is that there will be what we call cortical spreading depression. And what does this mean is actually, in simple terms, it means when you take these products, you will have what we call a slow propagating wave, where there are alteration of brain activity. And earlier on, we said pain occur when you have irritation, agitation, or stimulation of either muscles of the head and neck, or dura mater, or nerve number 5, which is trigeminal. So when these cortical spreading depression occur, you will have brain activity. There is alteration of brain activity, meaning you stimulate or you agitate for something. And when this is agitated, there will be some hypersensitivity followed by depolarization. And when there is depolarization of impulse in your brain, there will be some auras. Aura is something like something preceding something. And normally in migraine, you will have what we call scotomas. Scotomas is a loss of vision, or somebody will present with, will tell you, I have before experiencing this type of headache, I will have what we call a dark vision. So when there is a cortical spreading depression, means we'll have depolarization of some waves of impulses in brain. And when these occur, the waves will spread until it touches the noise receptors or the pain receptors around the nerve number 5, either peripherally or centrally. And when it touches the receptors around this nerve, it will trigger what we call um, calcitonin gene receptor peptide, which is the primary neuropeptide around this trigeminal nerve. So when this wave occur, there will be depolarization, and when there is depolarization, it will end up touching the receptors or noise receptors in trigeminal nerve, or pain receptors. As you understand, the trigeminal nerve trigeminal nerve is the one that perceive pain or send a pain impulse, and it's among the 12 cranial nerves. And we can say the other 12 cranial nerves include olfactory, which is for sense and smell. Another one is optic, which is for ability to see. Another one is oculomotor, that's ability to move your eye and blink. We have trochlear, that's ability to move your eye up and down. Another one we can have is nerve number 5, that is trigeminal, for sense around your eye. And then Vase, jig, and jaws. So that is why we are dealing in num number 5 because for sensation around your head, jaw or cheeks. Another number 6 is abduction nerve, that's ability to move your eye. Another one is the visual nerve, that's number 7. That's for expression or sense of taste. Number 8, we have what we call auditory or vestibular nerve, that's ability for hearing. It will enable you to hear. Another one that's number 9 is glossopharyngeal nerve, that is for taste and swallow. Another number 10 is about a vagus nerve. Vagus nerve is for for digestion, heart rate, and even for co-reflex is where we have vagus nerve. Number 11, we have accessory nerve or spinal accessory, that is for movement of your shoulder and neck. And then another one is hypoglossal nerve, that is for ability to move your tongue. But actually here we'll deal only with trigeminal nerve because for pain sensation. So we have said when there is a cortical spreading depression, it will stimulate depolarization, and when this depolarization occur, it will send impulses which will end up activating the noise receptor or the pain receptor. This is being preceded by an aura. An aura, majorly scotomas. I think it's good to note scotoma because it's a major presentation of migraine headache. So when these impulses has been sent to noise receptor, the noise receptor will activate a primary neuropeptide in the trigeminal system, and these neuropeptide, that is calcitonin gene receptor peptide, have what we call uh, vasodilatory effect. Vasodilatory meaning the vascular region around these nerve receptors will have to dilate, and when it dilates, it increases permeability, meaning they become more leaky. And when it leaks, meaning the substance inside will start to move outside. And when it starts to move outside, it will cause what we call inflammation. So when inflammation occur, it will activate the pain receptor. As you understand the signs, among the signs and symptoms of inflammation, we have what we call pain. So it will trigger pain receptors, and when there is pain receptors in this nerve, it will be a relay of information to trigeminal nuclei, and when the information is sent to trigeminal nuclei will send impulse to thalamus, and when it send information to thalamus, it will relay information to the cortical sensory cortex. When information is sent to the sensory cortex, it will perceive the information, and what is being perceived there is actually pain. And what is pain? Pain in the head is headache. That is how migraine headache occur. So the first thing you need to know on how it occurs is about cortical spreading depression. This is the alteration of activity that will propagate a wave of movement or impulses in your brain. There is devolarization of impulses in your brain, and these impulses will stimulate the pain receptors or the noise receptors in a trigeminal nerve. And when this is being triggered, it will trigger production of what we call neuropeptide, that is calcitonin gene receptor peptide, that is a vasodilatory effect. That has a vasodilatory effect, and this vasodilatory effect will increase the permeability of vascular region around the trigeminal nerve. And when it is increased, it will start to become more leaky, and when it becomes more leaky, it means there will be signs of inflammation, and among the signs of inflammation is pain. When pain is being perceived there, information will be relayed to the trigeminal nucleus or nuclei. When information is relayed to nucleus, it will be relayed to thalamus, and when the information is being relayed to thalamus, the information will end up being relayed to the sensory cortex, and then when in sensory cortex the information is being perceived, and what is being perceived there is pain. So when pain is perceived there, that's the cause of migraine headache. Actually, it's as simple as that. Another cause is low serotonin effect. It will stimulate the same pathway. It will have cortical spreading depression. Also in serotonin, low serotonin level, you will have a cortical spreading depression. And when cortical spreading depression occur, it will mean there is hypersensitivity in your brain, and then it will, despite this depolarization effect, and then effect will cause this type of headache. and it is being preceded by auras. You should mark that when this is uh, when this when these when all of these activities happening, there must be a precipitation of an aura. Mean all this activity is being preceded by an aura, something that precedes something before it happens. So and the most common is scotomas. So let's proceed. That's how migraine headache occurs. Let's proceed. Let's look at the cluster pain. So in this type of headache, they are being triggered by some substance like red wine, smoke, and even stress. So when all of these factors uh, are there, it will stimulate the inactive part of the brain, that is hypothalamus. And when hypothalamus is being triggered, it will trigger the parasympathetic nervous system. And when the parasympathetic nervous system is stimulated, there will be relay of information whereby spinal ganglion will be stimulated also. And when spinal ganglion is stimulated, there will be release or bypass to some glands like lacrimal glands, nasal glands, whereby they will secrete some secretions there, like they will undergo lacrimation or nasal secretion. So it is simple as that. There is a stimulation of hypothalamus. Hypothalamus will trigger a parasympathetic effect. Parasympathetic nervous system will stimulate some impulse, which will cause spinal ganglion to relay information to some glands like lacrimal glands or nasal glands to secrete their secretion. And when there is a secretion, it means there is increase in permeability of this blood vessel around this area. And when there is increase in permeability around this area, there is inflammation. And what type of inflammation is that? It will cause what we call neurogenic inflammation, as simple as that. So it will cause neurogenic inflammation. So what happen is that when this neurogenic inflammation is goes, it will cause activation of near cranial nerve. And what happens is the near cranial nerve, there is trigeminal nerve. So when there is a trigeminal nerve as being stimulated, it will relay information to the thalamus nuclei to the cerebral cortex. Under cerebral cortex, the information is being perceived there. And what is being perceived there is pain. And what is pain in the head? It is headache. So that's how cluster pain happen. It's as simple as that. This activation of hypothalamus by these triggers like red wine, smoke, or stress. And then when hypothalamus is being triggered, this will goes parasympathetic nervous system to stimulate the production of impulse in spinal ganglion. And when there is production of impulse in spinal ganglion, there is stimulation of secretion from some glands like lacrimal gland, nasal gland. And when there is production of secretion in this, they will cause neurogenic inflammation around the tissue because of increase in permeability. And when these um, inflammation occur, it means it will cause activation of cranial nerve. That's number 5. And the information will be relayed to thalamus to cerebral cortex. And under the cerebral cortex, it will cause neurogenic, it will cause perception of pain. And that is how it happens. Another thing we need to know is what happened with this neurogenic inflammation, that it activates what we call cavernous sinuses. Cavernous sinuses are the dural venous sinuses that communicate to each other, and mostly in the temporal region. So when this cavernous system is being stimulated, it will cause production or permeability of the venous vessels around this region. And when it causes this inflammation or this permeability in this vein and this venous region, it will cause what we call inflammation. And when it happens, it will relay sympathetic bypass. And when it relay the sympathetic bypass, it will cause what we call increased blood flow to the eye, causing meiosis. And meiosis is just a small or contracted pupil. And also it will cause what we call proptosis. Proptosis is bulging of the one or both eyes. So what you need to know is the another effect of neurogenic inflammation is that it will activate a cavernous sinuses. And what it this means is that Cavernous sinuses is simple dural venous sinuses that communicate around each other. So in this, when it is being implemented, it will means that the outer part will be more permeable, and the end part will have sympathetic bypass that will cause pressure or increase in blood flow to the eye or conjunctiva, causing what you call meiosis or small pupil or constricted pupil, and what we call proptosis, meaning bulging of one or both eyes. So what you need to know majorly is that how does cluster brain occurs? Activation of hypothalamus, which is a dormant part of the brain. And what happens when hypothalamus is being triggered? It means it will trigger the parasympathetic nervous system. And what happens when parasympathetic nervous system happen? It means it will stimulate the spinal ganglion organs or nervous system to relay some impulse to glands like lacrimal glands or nasal glands to secrete a secretion. And what happens when this secretion is secreted? It will mean it will increase permeability of their vessels around the zero. And when there is increased permeability, it will mean there will be signs of inflammation. And what type of inflammation? Urogenic inflammation. And what happen in this is there will be activation of nerve number 5, that is trigeminal nerve, and then impulse will be sent to thalamus to cerebral cortex. It is as simple as that. Let's proceed. Let's see tension headache, and it's the common type of headache. Tension headache. Let's actually tension headache is the common, followed by a migraine, and then the last one is cluster pain. What we need to know is triggers are like muscle tenderness, dehydration, sleep decrease or lack of sleep. These are the things that triggers tension headache. All these causes tenderness of muscles perichinal region like neck and shoulder. So, as under our definition of headache, we said pain around the head being triggered, agitated, or stimulated by anything that happen on muscles on the head or neck, dura mater, or nerve number 5, that is trigeminal. So under this we'll be looking at the muscles. The more it goes is tenderness around the muscles on the head or neck and shoulder. So when there is something that is stressing muscles on the neck or shoulder, they will activate the blood vessels around these regions, and then there is activation of blood around these regions. They become more permeable, and when they become permeable, there is nervous fiber around this region that relay information, and it happened to be nerve number 5 also. We send impulse to trigeminal nuclei up to thalamus to cerebral cortex. So when there is tenderness around this region, it means it will affect the blood pressures around this region, and it has nerve fibers that happen to be nerve number 5, that's trigeminal, and the information will be relayed to the trigeminal nuclei, to thalamus and cerebral cortex. So what you need to know is also if tension headache occur over a long time or over a long period of time, it will cause what we call central sensation, which presents with worsening headache, and it's called hyperpyrexia. So somebody can present with hyperpyrexia or extreme painful pain because of uh, over repetition of tension headache over and over and over. So what you can draw from here is that all these headache triggers nerve number 5, whichever the way they use or whichever the way they trigger. The important points is they will all trigger nerve number 5, which will relay information to trigeminal nuclei in the brain, and under the trigeminal nuclei it will relay information to the thalamus, and under thalamus information will be relayed to cerebral cortex, and cerebral cortex is where pain will be perceived. And what means is pain in the head. And what is pain in the head? It's simple as that, it's an headache. So that's how all these type of headache happen. There is the same despite the fact that the origin it will have a midpoint whereby they will all trigger a nerve number 5, and that happened to be number 5 nerve, that is a trigeminal. So let's look at their signs and symptoms, or how they manifest themselves. So let's start with a migraine. Let's look at the clinical features of migraine headache. Let's use the bound procedure. Photophobia. These people will have photophobia, because we said this patient will have what we call aura. Aura is something that it precedes darkness. They will have what we call scotomas. Scotomas is just something like darkness. So this pain is pulsating in another way. So you will have something, patient will tell you I have darkness, I don't see well, or loss of vision. So B will have photophobia, or you will have 1 day duration. The day of this pain will last for 1 day, and then it's unilateral near orbital region. It's around the eye, and it's unilateral one side of the head. N is nausea and vomiting. 3 is disabling in intensity. It's an extreme pain that will be disabling. So let's look at auras. If the cortical spreading depression occur in occipital region, you will have visual problem, eye scotomas, as we have said. When these irritations occur back at the occipital region, back of the head. When these occur at the back of the head, it will mean you will have some auras, and mostly visual auras, that is scotomas. If it's from the sensory cortex, you will have what we call sensory abnormalities, and you may have paralysis of numbness of some of the body. So if it occurs on occipital region, you will have visual problem, that's scotoma. If aura occur on the sensory cortex, you will have sensory abnormalities, and you will have paralysis, numbness of part of the head. If it involves the motor, you will have a motor problem, and commonly will present with weakness of one part of the body. So that's happened. If it happen in the brain stem, you will have what we call brainstem auras, where you will have diplopia. So when it involves the retina, you will have what we call retina aura, and it will have what we call ocular migraine. So depending the region, you will have different types of auras. So what you need to know about this is that you may have people with what we call hemiplegia migraine. Most people have unilateral weakness, and mostly lasting for 73 hours. So these people will have what we call hemiplegia migraine, means these people will have a type of migraine headache that you will have unilateral weakness. Some part of the body become weakness, and it will last up to 72 hours. So that is what we call hemiplegia migraine. Point to note about migraine headache is that you can be about hemiplegia migraine is that it can be misdiagnosed with stroke, because stroke also present with unilateral weakness. That one can last for a longer time. So you need to be more keen when it comes to stroke and migraine headache, hemiplegia migraine headache, because it can be misdiagnosed for stroke. So how do you to differentiate between stroke and hemiplegia migraine? You need to take MRI of a brain, so that you can know if there is any other thing apart from signs, apart from these signs. So let's look at the clinical features of cluster headache. Cluster headaches also is unilateral pain on orbital or super orbital or frontal region. It has a stabbing pain, a very sharp pain, panning or stabbing or sharp pain. And then what guidance is the pains starts and between 5 minutes to 3 hours. It will start from 5 minutes to 3 hours, and it happens in clusters. What do that mean is that it happened if headache developed today at around 12 p.m. After 3 days at around 12 p.m. also you'll have experienced the same type of headache at a specific time, and even the specific region of the head. So that is what we mean by clusters. It happens at an interval, or after sometimes it reoccur at the same time at the same region of the head. You will have rhinorrhea, because you will see when hypothalamus is being triggered, it will trigger the parasympathetic nervous system, and when the parasympathetic nervous system is being stimulated, it will stimulate the spinal ganglion system to stimulate some glands like the lacrimal gland or nasal glands to secrete a secretion. So those secretion we call it rhinorrhea. That's secretion around the nose. We have lacrimation because of that effect of spinal ganglia stimulating them. We have conjunctival hyperemia. There is blood in the conjunctival region. We seen the effect of neurogenic inflammation is that it will cause what we call cavernous sinuses, because what happen in cavernous sinus is that there is increase in the end part will have what you call sympathetic bypass, which stimulate high pressure or blood to the end part, what we call conjunctiva, causing meiosis, that is constriction of air, or the pupil becomes small, or proptosis, that is bulging of the eye because of the effect of the neurogenic inflammation of the dural sinuses, venous sinuses. So that's another sign. So another one is the patient become restless. People having this type of headache are very restless. You need also to make them rest. So let's look at the clinical features of tension headache. So in tension headache, this take a note. This type of pain is bilateral, and it's also mostly on the frontal and temporal areas, and it's not throbbing. It has pan like, it's like let's if you take a band and wrap around your head, is pan like, it's like there's a band on your end, band like, it's like you are press your head with a band. So it's bilateral around frontal and temporal area. It's not throbbing, it's not sharp, and it's lasts up to 30 minutes and can go up to 46 hours. Even it can last for 1 week. So that pain can uh, go up to 46 hours, and also can last for hours. It's not pulsating. There is no photobobia in this. There is no those auras. So those are the clinical features of attention headache, the clinical features of cluster vein, clinical features of migraine. So let's proceed. Let's see on how we can diagnose headache, all this type of headache. So one, if there's a aura in migraine, when there is an aura, it should be 2 or more episodes of aura. When a patient comes to you with two or more episodes of aura, you can define that as a migraine, and mostly there's scotomas. If there is no migraine, it should be more than 5 episodes in order to diagnose migraine. It should be more than 5 attacks. If there is no aura, there is nothing preceding this migraine, and we have seen the different signs or clinical features of this migraine, and we use the pound procedure where we had a pulsating effect. So those are the things onset. Those are the things you need to know, uh, to take note of, so that you can diagnose a migraine headache. So another thing is, it wasn't worse with exertion. When you do exercise, it get worse. So that's another thing you need to take note of a migraine headache. Let's see a cluster headache. It should be 5 episodes. You should have lacrimation. It should be agitated, or something stimulates. We have rhinorrhea. So those are also lacrimation. Lacrimation also is another thing that you should have in order to define this type of headache or cluster, and should be 5 episodes. So let's look at tension headaches. The simplest one to know is non-versatile. There is no photophobia, no auras. There is no vomiting, yes, no photophobia. There is bilateral, not worse with exertion. We've seen migraine and cluster being worsened by exertion. Another one is there is increased sensitivity to light sound with no aura. Those people are very sensitive to light and need to rest in a quiet room and where there is no noise. So let's look at the management of different types of headache. Let's start with a migraine. Those people should be placed in a quiet room. If that doesn't solve it, you can keep IV fluid, that is 1 liter of 0.9% normal saline, start, or keep antiemetic because of vomiting. We see those people will be vomiting also. Keep NSAID because of inflammation, like ibuprofen. So you can keep ibuprofen, and if these people are vomiting, you can give what we call IV ketorolac. If the patient is vomiting, you can keep triptans to stimulate serotonin. We see another cause of this migraine headache is low serotonin, which will stimulate cortical spreading depression, which will end up causing relay of information to cortex, whereby there will be perception of pain. So another one, if doesn't work, you can keep equals. You can keep to increase serotonin levels. You can keep dexamethasone. You may also keep prophylactic agents like propranolol, anticonvulsants, DSAs, which inhibit calcitonin channel, or calcitonin receptor that causes vasoconstriction in the head. Or you can keep Botox AI injection once a day in a week. It's once a day in a week. You can keep one time in a week. So that's management of migraine headache. Let's proceed. Let's see about management of cluster headache. Cluster headache, you can keep oxygen. You can keep version oxygen. Why keep oxygen? We see earlier on we see the effect of by hypothalamus being triggered is stimulation of parasympathetic effect. So when you keep when you keep oxygen, it will counterattack the parasympathetic effect in the brain, and it will relieve a patient. So you will give oxygen in order to counterattack the parasympathetic effect of hypothalamus being triggered. Another one is triptans. You can keep also ecots. Triptans and ecots will have an effect by increasing the serotonin levels, and when serotonin levels are being increased, it will counterattack the vasodilation of pains. And then we can have intranasal lignocaine. Why intranasal lignocaine? These are intranasal lignocaine uh, will help in relief of secretions, because it will make the nerves to be numb, so that it will not relay information. Another one is prophylactic therapy, where you can have verapamil, we can have a calcium channel blocker, and the convulsions, or prednisolone. So that's the management of cluster pain. Let's look at the management of attention headache. Um, sorry, sorry. So under sorry, under episodic under a management of attention headache, we can have episodic headache or chronic headache. On episodic headache, you can keep NSAID, NSAID, acetaminophen. You can need caffeine, or combination of the two. You can keep caffeine and NSAID, acetaminophen and caffeine, or NSAID and caffeine, or acetaminophen and NSAID. So you can give two combination, or you can give NSAID alone, acetaminophen or caffeine. When it comes to chronic headache, you can give as TSA, tricyclic acids, i.e. amitriptyline, or other include anticonvulsants. You can give anticonvulsants because it will help to counterattack the effect of parasympathetic nervous system causing inflammation in the brain. Another thing is you can do exercise, because we have seen it's a stress around what causes tension headache is stress around the neck region, and when stress being caused there, it will affect the blood vessels around this region, and when blood vessels are being affected in this region, it will stimulate the nervous fibers in this region that will trigger relay of information to the trigeminal nuclei, and then in trigeminal nuclei it will relay information to the thalamus nuclei, and in thalamus nuclei information will be relayed to the cerebral cortex, where there will be perception of pain. So physical exercise will help in tension headache. So we can proceed. So I think we can proceed. So let's look at the secondary causes of headache, and we have red flag signs of causes of secondary headache, and we have classified these red flags as follows, and it we have come up with a formula that helps us to define these red flags. That's a SNOOF formula. SNOOF formula. SNOOF means S means systemic system symptoms, which includes secondary causes like HIV and AIDS, malaria. We have neurological symptoms, is for N, old age, that's above 50 years. O, another O is onset and is abrupt and intense. P, Basvi means babeloedema. V is positional, worse when lying and better when awake. V, another V is pattern change. The way it presents is pattern change. Today it will be a little bit better, tomorrow it's worse. V, it will mean precipitation or Valsalva maneuver. So those are the things that will be red signs of this kind of headache. So let's proceed. Let's see the causes. One is mass occupying lesion. When you have a mass occupying lesion, you will probably have increased blood in brain, and also there will be increase in CSF. For example, when you have epidural hematoma or any like subarachnoid hemorrhage, it will cause pain because there is increased pain around the brain, and even these lesions can press other tissue. So when there is another way is when you have increase in brain tissue, like in pituitary adenoma, where in patients with pituitary adenoma, the patient will have bitemporal hemianopia, vascular defect that lead to impair peripheral vision in the outer temporal halves of a visual field of the eye. Good damage of optic chiasmic due to a lesion like by Imanovia. So what does this means? When you have a problem with your brain tissue, optic chiasmic is whereby the two visual nerves cross each other, and when these adenoma press, it will mean it will affect the ocular. You'll have a difficulty. It will affect. It will impair your peripheral vision because it has altered the activity of optic chiasmic, and this will have an impact because it will have an impact on your vision. Another thing is you will have headache also because when this tissue is being pressed, it will relay information to the trigeminal nerve, whereby the trigeminal nerve will relay information to the thalamus to the cortex. So that's another thing. So they may come with signs of proctalamia, and this is includes erectile dysfunction, infertility, small vessels, enlarged muscles in men, what we call gynecomastia. You can have